pediatric endocrinologist, part of the Childhood Obesity Research Center, and I've been one of the folks heading up this effort towards developing the Institute for Integrative Medicine and leading the steering committee with that really over the last 2 years. And you are all present at our second of monthly breakfast seminars, which are coming your way because of the Research Collaborative Fund Award that we received back in August, September, I think, came out. And just to put a little intention behind what that award's all about is it's really about building a research collaborative community here at USC in the field of integrative medicine and integrative health. So you may or may not be aware, but there's actually a national consortium now of 54 academic institutions that are doing academic integrative health across the country. There's a couple that are in Canada and in Mexico. So we've just joined that consortium. So I think the field of integrative medicine and integrative health is at a point in its development where it's really about to take off. And so it's really exciting to be bringing that to USC, to have the support of the Provost's office and the Office of Randy Hall Research, to be able to start to bring us all together, all of us who have, at least part of us, an interest in integrative medicine and integrative health, otherwise we wouldn't be here. So while the last couple people get in, I just want to also let you know how we want to kind of run these seminars. We are trying not to do kind of, you come, you sit, you see an hour presentation, and you go. We really want this to be, to build collaboration, so we need some time to be able to talk together, meet each other, so I encourage you to do that. We have some time beforehand each month with the breakfast, and providing some good, healthy breakfast foods, so we can all meet each other, see what we're doing, and over the course of time with each month, we'll know each other more and more, so that we can start to share ideas, build collaborations. Our speaker today is going to speak, we're envisioning our talks being not a full hour, but maybe 20 minutes to 30 minutes about some topic in integrative health, focused towards the research end, but certainly introducing different fields in integrative health, and then having some time after the talks to really open it up, not only for questions and answers to the speaker, but also for those of us who want to see this really start to get some juice here at USC, to talk amongst each other and say, hey, what can we do? What does this bring up? What potential projects? What potential collaborations? What funding mechanisms are out there? So that we can really start to develop the field here at USC. So that's basically the idea. I had in mind, not to put anybody on the spot, but since there's still people, let's just go around and mention names, departments, so we know who we're sitting with. There's a poem by William Stafford that I love. It's my favorite poem. He says, if you don't know the kind of person I am, and I don't know the kind of person you are, then the pattern others made in the world will prevail. And following the wrong God home, we may both miss our star. So I think it's important to know who you're sitting with. So we'll do it quickly because we don't want to take a lot of time. But if people just say their names, maybe what part of USC or outside USC they are, just so we kind of get the feel of integration in the room before I introduce Marissa. I'll start with you, Cheryl.
I'm Cheryl Resnick. I'm from the Division of Biokinesiology and Physical Therapy.
Hi, I'm Patty Harris. I am a physician, geriatrician.
I am Greg Taylor. I am a physician, geriatrician.
George Salem. I'm from the Division of Biokinesiology and Physical Therapy as well.
I'm Emma Lane. I'm a medical student, first year at CAP.
I'm Marla Aft. I'm a yoga teacher and I'm on the board of Iyengar Yoga and Therapeutics.
Arlene Zeichner, President, Iyengar Yoga Therapeutics.
Robin Howard, USC Physical Therapy. Sarah Ingersoll, Neurology, and I have to make a brief plug for the 5K training team for the season. They are going to be starting January 10th training for LA Marathon's 5K in March, and this is open to absolutely everyone. Has been primarily people with Parkinson's disease, but it's open to anybody who wants to train, who is a little uncertain about joining a more efficient group.
Jody Kurland. I'm a physical therapist at Children's Hospital.
Henry Slokey, Department of Psychiatry and Behavioral Sciences.
Christine LeBoy, Director of Research Administration in the Office of Research.
I'm Jeffrey Gold. I'm a pediatric psychologist. I come from Children's Hospital, Los Angeles, and It's great to see Jody here. So we're starting to get some CHLA integration. And I'm part of the Department of Anesthesiology and Pediatrics here at Keck School of Medicine.
Nick Vidar, I'm second-year med student, Keck.
I'm Jim Adams. I'm in the School of Pharmacy. I'm also a Chumash healer. That means Chumash Indians. And I've run 21 LA marathons.
Wow.
I'm Una Darian. I'm an Associate Director of Development and Foundation Relations for USC Norris.
Alex Slate with USC Occupational Therapy.
Christina Daly-Comright with Division of Biokinesiology and Physical Therapy.
Joanna Lee with the Institute for Global Health.
Susan Estelle, I'm a pain psychologist with the USC Pain Center.
Faye Weinstein, I'm also a pain psychologist at the USC Pain Center.
You want to tell us who you are? I'm not going to let you sneak in. Shine a spotlight on you.
My name's Christopher Walker. I'm from psychiatry.
Great. Well, it's quite a mix. So, and that is what what our vision is really a
Oh, you did?
Oh,
Okay,
you did, yeah.
I'm sure I didn't miss anything.
multi-department, multi-school. It's kind of an interesting concept at a major university like this where most departments and activities are really siloed off in their little place. So how do we build those integrating links? So that's one of our big challenges, but it's great. I think the first thing is that people start showing up. And so it's really exciting to see you all and to have you here. And just a comment to the medical students, it's great to have you here. I just want to really accent the role that the medical students played in driving this whole thing, because they were pushing, from their perspective, knowing that they needed to learn about integrative medicine, integrative health, because it's out there, and there just wasn't much in the curriculum at Keck here. So we're all indebted to those really activist young people over the last couple of years who really pushed us faculty to kind of get our act together. So hopefully it's all synergizing now. Oh, okay. Marissa reminding me, if you see this week's HSC Weekly, there is an interview of myself and Dr. Debu Tripathi, who is one of the other leaders of our steering committee. So it talks about what we're trying to do. So, if you're new to our integrative health efforts, maybe you'll get a little bit of background here. So I encourage you to read that. Okay. Any questions before I introduce Marissa? All right, so it's my pleasure for this morning, for our second talk, to introduce Marissa Perdomo, who's in the Department of Physical Therapy and Biokinesiology, and who is hosting this event, by the way. We want to thank them for their graciousness and generosity in hosting us here today. So a little bit about Marissa. She's been a physical therapist since 1983-ish, if I remember right. I don't speak about birthdays, I gave that up a few years ago. She's been at USC for over 12 years, I think, and is really a leader in her department and in education and within physical therapy and developing their educational programs. And has really been also a driving force on our steering committee over the last 2 years to really bring this Institute of Integrative Health into a reality manifested in its current shape and ongoing shape. She's very active on the committee and helps keep us grounded. So we're very appreciative of that. So Marissa, the other thing she wanted me to let you know about is that she was born in New Orleans and therefore has an immense love of both music and food. So, because any good New Orleans would. So Marissa's going to speak to us today about physical therapy and its role in integrative health.
Thank you, Mark, and thanks everybody for getting here bright and early in December and the busiest time for our, at least for us to teach here. It's finals week for most of us. So physical therapy and the role in integrative health. I want this to be a very open discussion. I've kept the slides to a minimum so we can encourage discussion. So first of all, I like to start off with a phrase that I learned early as a student, that life is movement and movement is life. And when individuals stop moving, the quality of our life decreases. I'd also like to add to that the mind controls movement, both from a physiological perspective and from an emotional and psychological perspective. And then movement feeds back and controls the mind. We all have had clients or patients who have difficulty with movement, and that can lead to pain, it leads to stress, it can lead to depression, it changes in one's mood, changes in one's social structure, changes in one's function or role in the house or the home. And when we lose movement, it affects the whole person. And conversely, movement can also positively affect the mind, body, and spirit, which are kind of the three pillars of our integrated health and wellness institution. So here at USC, this is our vision of the potential role for physical therapy in integrative health. We believe that physical therapy has value in these three components of rehab, prevention, and wellness. And we're all familiar with rehab, acute post-injury, and somebody comes to physical therapy and we give our interventions, and now we're past the acute phase. Prevention, what I'm talking about here, might not be quite the right word, but I wanted to address that we also address the compensatory patterns of movement that develop as a result of some sort of injury or dysfunction. And a key component is that these compensatory patterns may be fixable or they may be permanent. So if we have individuals that have permanent loss of a movement pattern, whether it's from a stroke or from an amputated foot or whether it's from a neuropathy, there's many different causes, we will teach them to optimize whatever function they have within the context that they're never going to get full normal anatomical and physiological function. And then as we move through wellness, we look at wellness as a general health and physical fitness and well-being. And individuals will go back and forth through this continuum from rehabilitation to wellness, and physical therapy can play a role in all three phases, and then we also can play a role in the research in all three of those domains. Also where we feel physical therapy has a key role is in the concept of wellness in individuals who have permanent physical limitations. These individuals, if you think about it, have a lot of difficulty going to Gold's Gym or 24-hour fitness, and all of a sudden they have to do this exercise program in that context. And we feel that physical therapy can provide them a pathway to wellness as well. When we put this slide together, and just to give an introduction to how the flow of physical therapy or the role it plays. So when a person comes to physical therapy, they receive an evaluation, and the physical therapist has to make the decision, typically they need individualized physical therapy program. So they're going to come to the clinic and we're going to treat them. But also in some situations, and we have at the clinic, we have we have more than two, we have several group physical therapy exercise programs where if a person comes to physical therapy, they have limitations that need guidance, but maybe they don't need so much structured hands-on physical therapy. They can go into a group physical therapy exercise program. For example, we have a head and neck cancer exercise group where people may be a couple of years post their treatment, but they still have some limitations, but maybe they don't need us to be hands-on, but they can come and we can give a supervised group exercise program. As our clients are making the transition from an individual physical therapy program to a community-based program, there's this phase where they still need some guidance and correction and advancement by a physical therapist. And as we're transitioning them to their independent community-based program, we can provide a physical therapy guided yoga program or physical therapy Pilates program. as we're preparing them for their independence. We also can provide a guided return to a sports or a specific physical activity that they need to do. So the other aspect of our integrated health is the concept of mindfulness and meditation, and Mark talked at our last monthly meeting quite nicely about mindfulness. And this is something that in the traditional physical therapy world, they may use the word focus. They may not use the word mindfulness. They may say, okay, I want you to focus on your body. I want you to feel this muscle, feel this movement. Now, get your mind and body connected so that when you do this movement, it's purposeful. But it's a role that definitely could be expanded. There are some physical therapists, I wouldn't say it's mainstream, that will have the patient use imagery of a movement pattern. They'll have them meditate or use imagery thinking about the movement pattern and visualizing them doing the movement pattern, and then they go to practice it. But I feel like that's something that we can also integrate a lot more efficiently. Am I talking too fast?
Perfect.
Okay. And sorry, I'm using my hands all the time, so I can't talk about that. So our national organization, the American Physical Therapy Association, this is our vision. It's called Vision 2020 because we want to achieve many objectives by 2020. The first one, and I think we're almost there, is that all physical therapy graduates will have a doctorate degree. So we'll have doctors of physical therapy. We practice presently evidence-based. We are evidence-based rehabilitation specialists. Our association is very active in promoting physical therapy, developing more research. So, for example, I'm on 2 national committees that are looking at evidence-based evaluation and assessment tools and evidence-based interventions for individuals who have breast cancer, and then the other group is individuals who develop lymphedema as a result of any cancer. And so we're looking at the evidence and basically we'll develop a clinical practice guideline for physical therapists. Just another area showing our research. One of the key areas is that we are the experts in movement analysis. And I'll talk a little bit more, but when we talk about movement analysis, it's integrating the physiological and the anatomical components of movement, but then it's also looking at the entire body and looking at how the person moves, looks at how they plan that movement. We call that motor planning. And we look at neuromuscular control. We'll talk about that in a minute. And key is that we are, in our opinion, practitioners of choice where consumers will be able to have direct access. And I think it's almost 40 states now, Cheryl?
Not very enough.
40 states we have direct access in 40 states. So we're definitely making gains for that. So that we can make a diagnosis, intervention, and prevention of basically impairments, functional limitations, and disabilities that relate to movement, function, and health. So we go from disability through wellness. So, many clinicians use the International Classification of Function model. So do we. That's what I wanted to just bring up here. And, you talk about physical therapists, and if you ask them, they'll say, oh yes, we're very well integrated. We practice integrated medicine because we look at the whole person. We look at the health condition and its impact on an individual's bodily structures and anatomical structures and what functional impairments that cause. And then we take a look at those impairments and we say, okay, what activities that they have to perform, how are they limited? And then we say, okay, how are these activity limitations affecting this person's role in society? Their ability to work, their ability to be a caregiver, to be a mother, to be a brother. And we also incorporate and examine and question the patients about what environmental barriers do they have to movement, and then what are their own personal factors that may be limiting them in this movement dysfunction. So specifically about movement analysis. When somebody has back pain, they can't bend down to pick up their child, they have shoulder pain, can't brush their hair, they can't sit at the computer and work, whatever the dysfunction is, one of the things that we evaluate is muscle performance. And if we will break muscle performance down into, do they have the strength to do this movement pattern? Do they have the muscle endurance to perform this pattern or this activity? And then do they have the necessary power to complete the task? When we look at range of motion, what is their joint integrity for that motion? And do they have the muscle length to move that joint throughout the full range that's required? Neuromuscular control. Is the person able, what is their motor planning sequencing? Are they recruiting the correct muscles in the correct pattern with the correct strength or power or endurance that's needed for that activity? Can they control that activity? And then, do they have an imbalance, or is their body balanced? Do they have balance to actually stand on one foot and perform the activity, as an example? Spinal alignment and posture, just inherent. We have to look at not just spinal alignment, but joint alignment, and see if they're moving in the correct planes of motion, if their axis of rotation is occurring in the correct pattern. And then people forget about this cardiopulmonary fitness. We have to have not just good muscle strength and joint action and neuromuscular control, but we actually have to have the ability to supply blood to our entire tissues for this activity. And when we talk about cardiopulmonary endurance, but we're also talking about what is the quality of the venous and the arterial system. If there's a compromise in the venous system or a compromise in the arterial system, it's going to affect whatever movement pattern we're addressing. Physical therapists, we perform therapeutic exercise, and I have a couple of slides on this because people sometimes don't really understand the extent of what is therapeutic exercise. And therapeutic exercise is basically a systematic planned performance of movement, postures, and activities. And we need to remember that when an individual is injured, their prior movement pattern that was automatic for years and years of performing those activities is now disturbed. And so when we work with the patient, we basically have to reteach them how to move because of this injury or dysfunction or impairment. They now have altered movement patterns. And that can lead to subsequent other issues. So not only are we just gaining strength, because a lot of exercise enthusiasts can teach you how to gain strength. You can go to a gym and lift weights or get on a machine, but it's more how you take that strength and use that motor recruitment to develop a normal or optimal movement pattern. The next thing is that we have to remember that as physical therapists, we are looking at tissue, our systems, whether it's the cardiopulmonary system or the integumentary system, neuromuscular system, that has been injured. It's been traumatized. It's very different to exercise an injured tissue than it is to take a healthy person and put them in a gym and exercise. When we evaluate the patient, let's say this person comes in with back or hip pain, we evaluate them, and we're going to try and find the source of that problem, and then we have to choose an exercise program that's going to be limited by the amount of stress or damage done to a particular tissue or system. So in this example, we are performing a progression. This is the easiest of core stabilization. So we're actually having them engage their abdominal muscles, engage the pelvic floor muscles, and engage the multifidi. And so their core becomes stable, and now they add movement, and the arms are moving. So it's a little bit shorter lever arm than the legs. And if they can move their arms independently of their spine and pelvis moving, that's our goal. because we want the motion to occur from the glenohumeral joint. And once they come here, then maybe a next progression is let's increase that lever arm and make it challenge the exercise by having them move their legs into flexion and extension, still maintaining the abs, pelvic floor, and multifidi musculature stability. Then again, once the tissues can tolerate this load or stress, then we're going to move to, in this case, alternating arm and legs, and in this case, we put weights on their ankles. When they can do this, then let's say we get them upright against gravity. But part of our evaluation process is, were these tissues actually weak, or were they just not being recruited because of a poorly motor pattern that was adapted over years and years, so the brain now thinks that that's a normal movement pattern. So we have to retrain the movement pattern to help retrain the mind so that it becomes automatic again. And that's why I think this Integrative Health Center is key. We can do a lot of research in this area. So, in general, here's kind of outlined what we do. We evaluate the individual. We're trying to diagnose the cause or the source of the movement dysfunction. We're going to evaluate the compensatory movement pattern, and as I said earlier, sometimes this movement pattern has to be there, so we have to optimize it, or we want to get rid of it. We take objective measures to note progress. Obviously, we're developing our interventions. Our patients' goals, obviously, our interventions is geared to what the patient wants to get out of physical therapy. Prognosis, where we're integrating back the health condition. Outcome measures are huge for every individual that we treat. And then we also refer to many different healthcare providers. It could be a physician, it could be a dietitian, it could be OT, it could be a social worker, but then it could also be 2 community-based exercise programs. And we've had lots of discussions in our department about where do we refer patients to. You know, I can't just send somebody says they want to go back to yoga, or they want to go back to Pilates, or they want to go back to jazzercise, or whatever exercise program they want to do. Pole dancing, that became the big craze in Hollywood, you know. But how do they go? And that's why earlier when we talked about that transition from individual physical therapy to the community, we already, to some degree, provide a guided transition, saying like, okay, I'm going to see you once every other week. You're going to go to this Pilates class. These are the exercises that I know Pilates does and I don't want you to do. Or these are the exercises these are the poses that they do in some yoga classes. I don't want you to do these, and we explain why. But then we have the patient come back and, okay, we dialogue. And so it would be nice if we could set up maybe a research project, you know, to study that and look at that and see and actually document the outcomes of that.
Marisa, how many visits do patients get with physical therapists, typically?
Yeah, typically, our visits are based on their insurance carrier. It drives it, unless they want to pay cash. So, for example, Medicare, you can get anywhere from 10 to 12 visits per calendar year, is what that ends up being. Sometimes you can stretch it out to 15 if you don't charge appropriately, and instead of charging for an hour, you charge for 45 minutes. Other insurance companies will some have this like 10 visit limit per diagnosis. So then we learn to play that game. So you have neck pain and you have shoulder pain, where you get 10 visits for the neck pain, 10 visits for the shoulder pain.
But I think the important point is that the transition is key.
The transition is key, and that's where I think there's a definite lack in physical therapy and in research, and I think we can have a huge impact right there, and we can have a huge impact in integrating some of, like from Mark's talk about mindfulness. I think that's also a huge necessary and untapped area that this integrated center provides, that we can do some good work. Our outcome, whether or not our outcomes are the patient's goals of I just want to be able to walk, bend, sit, pick up my children, or I want to be able to go run a marathon. Whatever the patient's outcome is, we can get them there through a structured intervention. And obviously, progression to an independent, community-based exercise program, because we're not going to get it in 10 to 15 visits. So in talking with other clinicians that have been attending these meetings and talking with other physical therapists, I just put together just a couple of potential ideas. I mean, in our division alone, we already have George Salem, who's done research with yoga. We have Christina Deli, which you might have left, who's looking at exercise in breast cancer patients as a prevention for recurrence. So we have some studies that are presently going, but we can definitely, these are some examples of how we can truly be what our core mission is, integrated health, not just integration according to the ICF model, but the other components, the mind, body, and spirit. Mark and I have already talked about getting together, and anybody else who's interested in looking at what physical therapy interventions are presently being done for bone marrow transplant patients, and then can we add that component of mindfulness to it, and how will we assess that, since we have a bone marrow transplant unit here at Keck's Hospital. In the lymphedema world, the standard of care is this complex decongestive physical therapy program. But like I was talking with George, breathing has become almost a lost art in physical therapy. If you're old enough, since I was, graduated in 1983, breathing was a huge part of our rehabilitation program. But it's kind of like lost favor in the last 25 years because there's so many other hotter and maybe better modalities that come across. But we think that there is a definite role, especially in the lymphedema world, to really start looking at specific breathing exercises and meditation in stimulating parasympathetic nervous control and increasing lymphatic flow. One of the ideas I briefly talked with some of the OTs about is in post-cancer rehabilitation, after they finish with any individualized physical therapy needs, what about combining? They do a wonderful lifestyle redesign program where they help the patient actually get started on an exercise program. But what if we combined the physical therapist of actually initiating the exercise program, guiding them through it, along with the lifestyle redesign? And then repeating what I had said earlier is looking at this transition to an independent community-based program. Can we do some research perhaps with a Pilates-based program or a yoga-based program as we're transitioning the individual to the community? So anyway, thank you. This is the time for open discussion. This is just Bandelier National Park, one of my most favorite places in the world to go. If you've never been there, it's absolutely gorgeous.
What state is that in?
New Mexico. The cliff dwellings, the cave dwelling where the Anasazi Indian population suddenly disappeared and they can't figure out why. But the ruins are beautiful, and the energy is wonderful, and it's good. So do we have any questions? Anybody want to talk to somebody else? Does anybody?
Actually, Marisa, so I have an important question. Maybe Cheryl, you can help answer this question. It seems like such a natural fit that rehabilitation and CAM, I'm just going to use CAM therapy and with that involved, that could be yoga, that could be mindfulness, that could be meditation. It seems like such a natural fit, especially because pain is typically associated with what you do as a physical therapist. Why has the physical therapy world really been reluctant in using CAM therapies up until this point?
I mean, I could tell you my impression, and then Cheryl, I think for a while, there were a lot of therapies that had basically no evidence. too, like myofascial release, and then there's unwinding, and then there's visceral manipulation, and there's all these things. And in the wave of insurance reform, the association said, hey, we have to actually start doing research so that we can show and demonstrate that what we do is beneficial. And so I think once the push came, starting in the late 80s, early 90s, to start developing research-based programs to help combat this, the insurance companies saying, hey, you know, why should we pay you this amount of money for these visits? Then I think we took a step back and everybody said, okay, you know, let's see if A plus B equals C, and then all of a sudden, CAM, for lack of a better term, that wasn't really available for us to do that then. So then the shift was, well, let's prove what we do works first. And I think now, you know, 2012, the influence is, hey, you know, we have to bring the mind and the spirit back into physical therapy, especially when we're looking at from the ICF model of the whole person. So I just kind of think we kind of come full circle.
Cheryl, do you have any comments?
Yeah, and I'm even older than Marisa.
Cheryl,
So-
tell us what's your title?
I'm the associate chair and associate professor of clinical physical therapy.
I mean,
Director of community outreach. What title?
president.
Past president of the California PT Association.
Okay.
But that's so.
You're dentist.
Pick a day. I'll give you a different title.
No, but I think that
So-
because of that title, you have a perspective.
And the age thing. So my area of expertise has always been catastrophic injury, and I spent 14 years at Rancho. And back in the good old days, when we got 6 months to take care of somebody who was status post spinal injury, and certainly 3 months for somebody who's status post stroke, you get to do a lot of things. And we had rec therapy, and we had psychologists, and we had social workers, and we really had, not the rest of the world, but I would say at Rancho, we had an integrated approach to looking at the whole person because they had to go back out. Well, now, a person with quadriplegia gets 1 month in the hospital. And a person with a stroke gets about 7 to 21 days, depending on how terrible the stroke is. Nobody is rehabilitated, and I think everybody's had to hunker down and deal with what is my area of expertise and what do I have to add to this equation to help this patient, because they're going to be gone. The fact that we don't have a healthcare system in the United States, I believe is criminal, and I think that maybe if we are able to put something together here where we can bring research to bear, then we can prove that integrating healthcare serves the patient and serves society better. But when you've got 6 visits, which is kind of an average insurance rehabilitation for something that could be pretty awful, a rotator cuff tear, well, you know, what if it's your dominant arm? You know, you can't, what do you do? So we've been kind of saying, okay, you're ready to go out in the community, and people are not ready to go out in the community. I've watched healthy people in the gym working and gone over to the personal trainers and said, you need to step over there because that person's going to hurt themselves. So I think we have a chance to be a leader in proving that integration is key.
Can I offer you a challenge, or anyone else?
I'm up. I'm free on Thursday.
Given your age, but your experience, and particularly on, it sounds like on policy levels even. Okay, so right now is an opportunity because of the Affordable Care Act, and the states are developing these insurance exchanges. And the state insurance, well, if they're blue states, the state insurance commissioner who's developing their insurance exchange is right now going through the process of determining what services will be covered and for how long, da-da-da-da-da-da. And there actually is a group forming under Margaret Chesney, who's the head of integrative medicine at Osher Center in UCSF, to try to interact with those policy decisions that are happening right now. So she emailed me a month or so ago, and I said I'd be looking for somebody at USC who might want to dig into the policy. So I don't know if you're interested or if anybody else is interested, but this is the time, because once they make those decisions, they apparently just decided that acupuncture, for instance, can be a covered service by all health providers in this is for the whole state of California. So other modalities, maybe length of time for rehab or something like that. All these decisions are being made, by the insurance commissioners as we speak. So if anybody wants to get their voice heard in that process, let me know and I can plug you into what's happening through UCSF.
One last thing, another comment I'd like to make, and I've gotten this feedback from other physical therapists and from Dr. Gordon, who's the chair of this division, is that in the 80s, the APTA really made a decision that they wanted to be considered mainstream medicine. They didn't want to be, because up to that time, oftentimes physical therapy was considered CAM, an alternative approach, not, correct me if I'm wrong, guys, but not, for example, wouldn't be direct access, et cetera, et cetera. And because of that, really there was this push away from the incorporation of any kind of CAM modalities with typical physical therapy.
Yeah, I mean, we were struggling for respect as part of mainstream medicine. We were always considered sometimes, unless it was a stroke or an amputee where it was, or post-polio, where physical therapy was understood to be beneficial, we were considered like, oh yeah, maybe, But in order to gain that respect and to show that we had a scientific basis for what we did, we moved away from CAM.
And so, I think there's a great opportunity here. And because of this, because there's been this push, I think people are now recognizing, and a lot of this, as you mentioned, Mark, is being driven by the consumer, by the patient, saying, hey, they're doing yoga at UCLA, how come we don't have yoga here? They're doing acupuncture at this other hospital, how come we're not doing this kind of stuff here? And it's a great opportunity for physical therapy and I think being the #1 physical therapy program in the country, I think we have an opportunity to be leaders in this area.
Yeah, I want to comment on that. I'm sorry. Okay.
I'm Dave Baxter. I was there. It's another 7 o'clock meeting. But one of the things I wanted, when they opened the Office of Complementary Alternative Medicine at the NIH, I was actually with Joe Jacobson. I was at the NIH, and I was a psychiatric consultant of that with John Spencer. And the issues that you raised and what came up is that there was severe criticism that this wasn't real science, and that, in fact, the grants that came in, I was on the 3-person committee that reviewed all the original grants that came in, and they were total garbage. And what happened is what was meant to set the field up to get credibility actually set it back. All the NIH scientists said, look at this stuff. There was a place called the Baxter Institute, which I don't know anything about. And they got huge funding, and it was the laughingstock of the NIH. And what happened, and I come from a background, I've been very interested in it. I was trained as a DO, but I did all my graduate training here at SC. And I think there is a wonderful opportunity now, but I just want to share a historic perspective. It has to be credible, good science.
Right.
One of the things when I was at NIH is everyone said, listen, these people don't know, quote, they don't know science, and there were all kinds of pejorative terms that were used. I was the only DO I was the deputy clinical director of the NIMH, and I said, no, it's just because there's not good science doesn't mean there's not something very valuable there. And I think we do have an opportunity here. Now, when I came here to SC, I came back, I did my graduate work and residency and fellowship here. I came back after 30 years, 3 years ago, and I started a center here, the Center for Exercise Psychiatry and Sport. Because I think one of the areas that we can really go is looking at, and there is a robust data that's out there on the role of exercise and movement. And I think we do have an opportunity, but I would really strongly encourage us to do good quality science. And I think that's what has really hurt the field more than anything. A lot of people who say, well, it works because I say it works. And then it becomes more of a religion than a science. And I think there are wonderful opportunities, and UCLA has done a very credible job. But unfortunately, that's not the general view. So I think what we can do, we have an opportunity, is to work together. Again, we're very fortunate we have experienced researchers here. We have the brand of USC. We're a university that's known to have a strong interest in movement and activity in sports. And I think there is an opportunity, but I would tell you and implore us, we're all Trojans here now, that we've got to do good science. And good science, there is still funding. You know, Joe Jacobson left, and now there's been another, I don't even know who's the head of the institute now, but John Spencer is still a consultant for them. They are still trying for people to do good quality science, because there's a number of people in Congress who still want to, continue to support this. But the field has been set back. Complementary alternative medicine, I believe, got sent back in the late 80s because people going in and said, we don't have to do science, we just know it works. And that's not the approach that I think any of us want to have. But for those of you who are interested in doing this, we had one R1 when I went from the NIH to Temple. I think we do some wonderful things here, but we need to really work together. And I think a multidisciplinary approach with people from different disciplines, and PT and OT are not considered really alternative. These were considered some of the things because of the National Rehab Institute, because of the work at Rancho, which was known in Washington. So I think we have some really wonderful opportunities, but we have to be very cautious because there are a lot of people that are looking for the one weak link in the chain, and then they discount everything.
I mean, this is the gospel that we've preached for 2 years as we put this together. So I think, the hearing that is just music to our ears. I'm sure everybody in the room. I think that, we have to drive it through evidence-based practices from a research standpoint. This RCF is a research funded by the provost and the research office. I mean, the whole idea is to drive research.
Like traumatic brain injury, for example. We've got the NFL contract. I know Rancho has done a lot. But really, Rancho tends to deal with the real train wrecks. And there's a real need for that.
Yeah.
But what we're seeing now is a huge momentum. I mean, some of the most recent monies I've gotten has been in the effects of mild TBI and how does that impact down the road. So certainly, as a neuropsychiatrist, I have interest in that. But I've been looking for colleagues to get involved more with the movement part of it. It's with the rehab, the physical therapy piece. Not just for the people who had Glasgow coma scales, but looking at these more subtle things who then develop issues with subtle movement. So I think there's tremendous opportunities. I know Beth is interested in this and the collaborative approach to it, but I think what we have to do is get together and form a real nice, tight package and go after, and there's a variety of funding sources. Not the least of which is the NFL is doling out money. It's largely political because they're setting themselves up for billion-dollar lawsuits that they're looking at. But there's still money is there, and I think we've got some tremendous expertise in grant writing, people who have been national heads of organizations, and those are the things that you can do, and you kind of market your credibility. But I'm sorry I couldn't get here earlier, but I think this is a really wonderful opportunity that we can establish ourselves as a true national leader in this field.
There's also the branch of NCAM. Yeah.
I'm sorry?
I was just going to say, and obviously the branch, the NCAM branch is really open to receiving CAM-based, interventions and
yeah, and as I said, I was, I just, kind of right place, right time.
Yeah.
But when it was myself, Joe Jacobson, and John Spencer, when it first got funded, and the big battle we fought was all the NIH people said, this is such a waste of money, this isn't real science, these people, and then all it took was one crazy application came. They said, there you go, they have no idea what science is. And that, to some degree, exists to this day. I think it's a little better, but I think there's an opportunity to really make some huge inroads.
Yeah, I mean, when you drill down at the NCAM, I'm sorry, when you drill down at the NCAM at their portfolio and look at what they have funded, there's some clear guidelines for what they're willing to get behind now, which is, good science.
And there is good science. I've sat on the study section for NCAM, and I see some really strong proposals, and the proposals I've seen I haven't seen a terrible proposal yet. So
well, originally there was...
I'm sure. Yeah,
back in '89, but I think it has progressed, and we have an opportunity, I think, to be a real leader.
So if there is a topic that we're talking about, and some of us are just sitting here and they're like, I'd like to work with this gentleman here, or I'd like to work with physical therapy, I think we need to use that mailing list and start emailing each other an idea so we can start forming some subcommittees to talk about developing a research protocol. That's, our purpose for today, for this group.
Yeah, I would even add maybe a little more macro than that. So there can be project-driven collaborations, but what you're bringing up for me is also something that, as we form this kind of nascent institute, we have it as there's a research center, an education center, clinical care. So you're sitting next to our current research director, Donna Sproutmetz. So one of the things that we envision, and maybe your comments can really spark it, is what's the next step for each of those centers. We really haven't started to develop them, but what I'm hearing really is a call for instance, the research center to have a meeting and let's brainstorm on a more macro scale. What you're talking about is how can USC really, how can we position ourselves, not for necessarily any one specific project, but just from a mind frame about looking at funding sources, looking at the types of projects we want to put in, the types of funding we want to go for, and what the various opportunities are, and then, start to develop those relationships and collaborations. So, I guess, Donna, I don't know if you have any comments on that, but that's what came up for me hearing what Dave was saying.
Yeah, well, I think that we're having our chairs meeting directly after this, and I think one of the things on the agenda is putting together, certainly for the research group, people who are interested in building the research part of this, to have a meeting and start hashing that out. So I have you, and I have you, and anybody else who wants to be had. My email is dmetz@usc.edu, and I will find you. And you can find.
I'd like to add that, I enjoyed your presentation a lot. Certainly PT is critical, and lifestyle changes are absolutely the first step. You need to add biofunctional food, in my opinion. In China, when you have a stroke, you're given dansun to help you recover from your stroke. Here in California, we have a functional food called chia. Whenever you have a stroke, you take chia. I'm a chumash healer. That's
No matter what type of stroke, there's different strokes. So
that's correct. No matter what kind of, that's correct. No matter what kind of stroke, and that can be researched. Okay, I worked on stroke for 15 years and have many publications on stroke.
Could you introduce yourself?
What?
Could you introduce yourself?
I did. I'm Jim Adams. I'm in the School of Pharmacy.
Yes,
where
I
I
understood.
I have 200 publications. I've been here 25 years. I'm a pharmacologist, but I'm also a chumash healer. So biofunctional food, I think, could add a lot to you. And the beauty of biofunctional foods is since they're not drugs, they don't have to go through all the FDA craziness. I'll just call it craziness and let it go at that.
But then this is an opportunity to put them to rigorous study.
Right.
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 So.
Yeah, as an arm, as a branch, movement, as well as what you're suggesting, I mean, absolutely could be studied in this context. Plus minus, that sort of different methodology makes a lot of sense. And we want you to introduce yourself thousands of times.
Great.
Because we're glad to have you here, all the way back to our meetings half a year ago. It's like, there's never too many times of an introduction.
First, I have one question. I've had occasion to actually be a patient of the physical therapy department, and I was amazed at the hum of activity there and the number of patients you guys are seeing. So I'm wondering if there's a way to build in almost a clinical practice research plan within the practice with standard outcomes, because
We already have
in
it.
pediatrics, our asthma program has it already built in. Every patient that comes to asthma clinic signs a research, what's it called? It's a consent
Yeah.
that whatever clinical data is developed can be used for subsequent, and it's a different. It may not be a randomized controlled trial, but it can generate hypotheses. It can give you preliminary data, and so I'm wondering about that possibility.
No, we do standardized questionnaires, intake and outcome summaries and evaluation, and I know one of our therapists is in charge of collecting the data from the head and neck cancer exercise group, from the general exercise population of cancer patients, and then all of our low back patients. So it could be definitely more formalized. I like the idea of everybody signing something when they first come for their initial value so that we can access all their data. I think we're doing it for specific populations, but not for everybody that walks in. So I think that's a great suggestion. It's a great place to start.
One of the big issues is, we're going to electronic medical record, and you have to get one that's database driven, and then it has to communicate with the overlords, which is very difficult.
But that is something that we're working strongly towards, and I like that suggestion.
Do you get mood rating scales on that? Because, I mean, you talk about something that'd be relatively easy to publish, regardless of whether one believes something works or doesn't work, if you don't have that data, showing a change in mood rating scales, there's a robust data, with the whole field of psychoneuroimmunology that demonstrates that if one shows a decrease in depression, you can measure lymphokines, cytokines, chemokines, there's a whole, that's not considered alternative at all. So regardless of whether we've been able to prove a particular strategy or technique, if you can demonstrate as a result of participating in this, patients report a decrease in anxiety, a decrease in mood state, that directly relates to morbidity and mortality with a whole robust field of data. The other thing we might want to think about is putting together a process paper. As we're putting this whole thing together, until we have a lot of content by going through the IRB and getting, which we should do, we can certainly talk about putting together a group of folks from different disciplines, and this is the goal of this, because process papers, it's certainly not the same impact as having data driven, but it also kind of does a little internal marketing and external. It tells people within USC, hey, this group is working together and they're already productive. They've published a process paper. It also lets the outside world know that USC has this thing going on, and it's more than just a breakfast meeting. These are folks who are serious about scholarship and are already making a contribution on how a university, an academic medical center institution might be moving towards this.
You brought up another important thing. If there's gold standard surveys that we should be thinking about giving our patients, it would be nice to know them. I never heard of a mood survey. We see quality of life, but this might be a good place to have a repository of wonderful scales to use.
Yeah, there's tons of them. And actually, some of the best ones for anxiety is just a simple visual analog scale that all the pain folks know. You can publish that. There's a whole bunch of real simple, user-friendly, patient-rated mood scales that take like 2 minutes and have been in the literature since 1962. The Beck depression, the Beck anxiety, and they're real simple to do. And that's data that you could publish rapidly, regardless of whether you've proven this particular technique, or even if you have people who don't believe in it. That can be a secondary project, but at least you can show by participating as patients felt less or more, very publishable. Again, then you start to develop a name recognition. We have our own brand within USC that people start looking, that's a center that's really doing something. They're looking at this in a rigorous scholarly way.
Well, I think that's what Mark is alluding to too, is having standardized protocols. I direct our pediatric pain management clinic at Children's, and we've got standard protocols that look at sleep, that look at mood, that look at function, HR, health-related quality of life, et cetera, et cetera, et cetera. So having those standardized protocols in place is great. Again, because then you can compare across places.
That data mining galore then.
Right, exactly. And then it really just puts you out at the front. And I do like that process paper idea as well. I think we've talked about that at our chairs meeting. Just so again, the RCF that we're granted here is both research and education. So the whole notion of educating our community locally, nationally, internationally is part of our mission too, making sure that they know that we're building, growing this sort of core in integrative health, and so I like that idea.
Is there an existing proposal that was, so this was funded, did you put together a proposal for that?
Yeah.
Yes.
And how
It was one of Randy Hall's collaborative things.
is that a 3-page proposal?
Five.
It was 5, the intro, yeah.
And it obviously has goals and a system.
Yes.
It seems
our
like
white
this is
paper.
half written.
It is. Yeah. It is, and it's a whip. It is, and it's a whip. It's a work in progress because, who knows who's going to show to these meetings? We could just all be staring at ourselves, but then we find out that psychiatry is showing up and PT showing up, and we have people from cinema and from world health. Who could have ever predicted dance that all these people were going to start showing up?
See, we also might want to consider a strategy of, within the medical school, those departments who are interested, start doing brain routes. It's such low-lying fruit. It lets people know what's going on, what are you doing? Because, the problem with all universities, we had the same thing when I was at Temple, when I was at Georgetown, and Hopkins, all the same thing. You don't even know what other people are doing. And,
in the office
you get together, that's right. Right
and the guy across the hall.
I've seen you at CSC many times.
Exactly, that's where my office is, right? So one of the things we might want to consider is I would have two maybe recommendations. One would be is to develop a few strategies that would be very easy, low-minded, like going out and seeing whose Grand Round series we could get on for this upcoming year, to let people know what we're here, what we're doing. Then you're going to find other people who are interested and say, oh, that sounds great, how can I get involved? The other thing I'd recommend is putting one person in charge of it, because what happens is you get lost in process paralysis, and everyone has a great idea, and then it doesn't follow through, or we all get busy, we got a million other things going on. Like if you have someone who's going to say, I'm going to take the lead on developing a Grand Rounds program, not this thing, but individual project. I'm going to take the lead on putting together a process paper. Because what happens, once you get committees tend to, everyone gets busy, and you get another projects, and things kind of just drag on a little, and then they lose momentum. You know, you always walk out of a meeting like this feeling really excited, and then 3 days later you're up to your eyeballs in your other work you're doing, and then it loses some of that initial steam.
3 days, you're so generous.
Being optimistic.
That's nice.
In terms of research and clinical applications, I would introduce the caveat here that we, in order to be scientifically or evidence-based, the word data refers to the dependent variable, and the dependent variable has got to be measurable, quantifiable, centimeters, grams, seconds. While mood is a nice byproduct, it is a byproduct. That is part of the reason that the scientific community, whether it's biochemistry or physics or whatever, has not accepted these kinds of conclusions. They're good hunches. They're hunches that one might want to put money down on, but they are not dependent variables. And as long as they're not dependent variables, they're not going to be accepted.
I think, with all due respect, I hear you, but I think that what the NIH movement is more towards biobehavioral outcomes. So a combination of biologics and also behavioral outcomes like mood seems to be acceptable.
Behavior and mood are separate items for me.
Okay.
Behavior is a dependent variable. What I am doing at this moment, where I am at this point, is observable. The initial, the middle name of the person about whom I'm thinking is not observable and never will be.
Right. But the constructs that we accept as psychologists and psychiatrists is the sense of behavior and mood, and we base our careers on those, so I think it's worthy of measurement, but maybe not as a standalone, but maybe as a...
definitely not.
Definitely something that we could do. Again, having a standardized protocol that taps all these domains, be them neuroendocrine outcomes, or be things like cortisol, or enkephalins or whatnot around stress, and also behavior, mood, sleep. These all seem to be really critical. As we move this field forward, that's really something that we need to be...
Just to go back to what Marissa was saying, when you're talking about range of motion, you're not talking about mood, you're talking about, again, CGS.
That's right, measurable outcomes.
And that's what we're about. I mean, ultimately, that is what we will be judged on.
Excuse me.
Excellent points. All we have to end and stop it there. And all of that can and should be discussed when the research committee gets together and starts working on what is our program going to target in terms of outcomes, etc. So I wanted to thank everyone. Before you run off, I want to introduce, for those who don't know, Camila Avila in the corner here. Thank you. And also, please, you want to mention the next talk, where it's going to be, when?
Yes, it will not be a lunch. I'm sorry, it will not be a breakfast. It's the only one that will be a lunch. It's in January 17th on the main campus. It's going to be in the School of Cinematic Arts. I will send an email about that. And then in February will be
at Children's Hospital.
Children's Hospital
for breakfast.
Wednesday, February 6th.
At the Saban Research.
At the Saban Research. And it may be a little bit complicated, so we'll send maps and stuff, information for you too.
So you parked in your biggest issue.
I'm going
Yeah, what's the woman's name from the cinema? I've always liked that her name.
Mariantina Gatsis from Cinematic Arts.